Bhatia and Dr. Lakshmi from Hyderabad and from Delhi. We hope to have a good fighting, but no blood. Huh?
Thank you, thank you.
Okay, I think the debate will be IPOM plus versus eTEP, right?
Yes.
Okay, Parveen.
Thank you very much for this opportunity to see Dr. David Lamento after so many years. When I went to Singapore and he came to Bhatia Global Hospital and Dr. Kriplani was also there, it is always a pleasure to meet Dr. David Lamento. And in this World Congress, we are having a debate about IPOM plus vis-a-vis eTEP RS. And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. When Dr. Sarfraz, Dr. Popat asked me that yes, we are going to have a debate on IPOM plus and eTEP, so I thought that he would request me to speak on eTEP RS. He said, no, this time, I know that you are doing a lot of eTEP RS, but this time you are going to speak in favor of IPOM plus rather than in favor of eTEP plus. And can you imagine, in one of the national conferences in Delhi also, I was made to speak on open inguinal hernia repair rather than laparoscopic inguinal repair. So today is the challenging situation, and I would ask Dr. Kona Kumari few questions once I start. That does the site and size of the defect matter? Is it a steep learning curve for learning eTEP RS, or it is a similar learning curve as IPOM plus and eTEP RS? Are you knowing or are you dealing with the complications in eTEP RS about, for example, posterior rectus sheath disruption? In IPOM plus, we had never ever heard even about these disruptions and the herniation of the intestines between the posterior rectus sheath and the peritoneum. And once you are doing eTEP RS for ventral hernia, for large size ventral hernia, and if you are not able to progress, then what is your fallback procedure? Are you converting the patient, or are you going and depending on age-old IPOM plus? All of us know that we started our IPOM from IPOM from 94 onwards, and till 2000 we were doing IPOM, but after that all of us realized that the chances of seroma formation were there, and we started doing the IPOM plus. And till date, lakhs and millions of IPOM plus have been done. But in how many situations have you heard, or has my worthy opponent heard, that the mesh had to be taken out? How many explantations? How many erosions? By the show of hands, how many of you have seen the fecal fistula after IPOM plus? Anyone? None? So what I mean to say, yes, one should be, and in eTEP, especially when you are learning eTEP, then and if you have some challenge, if the mesh infection occurs, then are you going to have the same kind of cascade of events as you had in mesh infection in inguinal region? And if the explantation has to be done, is it so easy the way eTEP has been done, or the way the mesh explantation has to be done? And there will be some recurrences. If you are not having any recurrences in your hand, nothing like it. But if there are recurrences even after eTEP RS, then what is the next step? And more important is that in last 4 decades or so, how many mesh explantations have you done, my worthy opponent? I know there are pros and cons of every procedure. Let's be very honest about it. I do not think that this kind of debate should be there between IPOM plus and eTEP RS. Both are good procedures, excellent procedures, but definitely there are certain group of patients who require IPOM plus. And there are certain group of patients in which we will not be able to offer them the IPOM plus. Maybe, for example, if the hernial size defect is more than 10 centimeter, 8 centimeter, and you are not able to close them easily, yes, we should learn, we should know how to do eTEP RS, and then we will be able to place in a larger size mesh. So in IPOM plus, the learning curve is definitely shorter, whereas in eTEP, the learning curve is very steep, even if you have been doing laparoscopic surgery for decades. What is the faster procedure? Is it eTEP RS? And world over, I would show you the studies also, it has been seen that IPOM plus definitely has a shorter procedure time, whereas eTEP may take 4 or 2, 6 to 7 hours. And what dissection is required in IPOM plus? Nothing. Whereas in eTEP RS, we have to go in between the layers, retromuscular space. If we are placing in a mesh, definitely a lot of dissection is required and lot of healing will also be there. And yes, there are chances of placing a nice mesh, easy kind of mesh in IPOM plus. But again and again, the caution is that initially all of us were taught that in IPOM plus you should make a margin of 3 to 5 centimeter and then the hernia recurrence will not be there. But we have learnt a lesson. No, it has to be hernia sac and hernia mesh area defect. Area has to be measured and then only you can reduce the recurrences. And what are the cons of IPOM plus, which she would definitely highlight? I know that higher risk of adhesions. Yes, any mesh we are going to place into the peritoneal cavity. Any laparotomy also, if you have done, and if you are going in for re-laparotomy for that person, adhesions are there. So who is going to think that adhesions will not be there? And are the adhesions going to change the life? No, they are not going to change the life. And again, yes, there are situations. If you do not, as she was also mentioning, if you do not do a good driving, you can have accident anyway. But if, for example, if you are leaving the mesh all around and you are not tacking or suturing the defect and the mesh can go inside the area, then definitely bowel obstruction can occur and erosion is definitely less. And all of us know that Igor Belinsky had described in 2017 about the eTEP business, and again realization was we have to place in the mesh in sub-retromuscular space, and then only the eTEP will be definitely better. So our thinking is that we should have the procedures for both. We should learn both, but again and again I am mentioning that for eTEP you have to train, untrain, train and relearn yourself more, and then you have to have lot of patience, and then only you will be able to perform the eTEP RS, because more dissection is required and longer operative time is there. And if we go into the details of hernia classification by EHS, all of us know for 4 centimeter, 5 centimeter, IPOM plus is an excellent answer. But if it is a more than W3 hernias, then definitely we have to go in for eTEP. And as we mentioned in the previous discussion also, a fool with a tool is still a fool. If you do not know how to create the space in a retromuscular space, and then you start doing eTEP, and then you start dissecting, and then you are not able to place in a good size mesh, definitely you are going to invite lot of troubles, and that will be a killing for the patient also. And in surgical endoscopy, there was a comparison of eTEP versus IPOM in incisional and ventral hernia repairs. Nobody can deny that eTEP takes longer time. And this was a study of 433 patients. Post-op pain is on day 1, day 7 and day 30. Day 1, yes, definitely eTEP pain is less, but on day 7 both are equal. And again, hospital stay also, if it has been done nicely, if you have been able to place in a larger size mesh 30 by 30, also comfortably after a good dissection, hospital stay may be less in eTEP, but in IPOM, yes, it is slightly more. And some people are pro cost. Our thinking is more than cost, we should value the value. if you know the value of the operation, if you are creating lot of problem, if you are placing a large size mesh, and if you have to, for example, God forbid, the patient has appendicitis later on, and then if you have to go in, or patient has cholecystectomy, needs cholecystectomy later on, and you have already placed 30 by 30 size mesh, and then definitely the cost will add on. And in this study also, it has been seen the seroma, hematoma, intraoperative complications, post-operative ILS, both of them are there, all the complications. And again, this publication in 2022 by Igor Belinsky only, he talks about pitfalls and complications of eTEP. And I would shy away from sharing this slide and the next slide, that so many complications and so much of percentages are there. Nobody can say that in eTEP RS you will not injure the nerves, you will not injure the viscera, you will not injure the bladder, you will not have pain or seroma or hematoma. So our thinking is definitely one should know both the procedures, and there are complications which are early complications, and there are complications which are late complications also. And you see the recurrence also of the order of literature says, I am not saying, literature also says the recurrence is of the order of 5 to 10%. And if the recurrence after eTEP RS is there, then what are we going to do? And similarly, people say that when you are injuring the linea alba, then also you can complicate. If you are injuring the linea semicularis, if you are injuring the neurovascular bundle, then also challenges can occur. So our thinking is, please do not go away with this idea that either extreme has to be followed, either IPOM or eTEP RS, and that's it. No, there are situations in which we definitely have that subset of patients who require eTEP RS, but there are more patients who require the IPOM plus. And if the all other, for example, previous, yes, I will just finish off that. For example, what should be your fallback? I am not going to show any video in this, but in the last, I would definitely say, learn both, unlearn, learn and relearn, practice till it hurts, keep practicing till it does not hurt. So I would definitely love to listen to Dr. Kona Kumari in favor of eTEP RS. Thank you very much. Thanks a lot.
Thank you, Dr. Parveen. You, unfortunately, women are always right. Then you start with the wrong foot. How many of you do IPOM plus? How many of you do eTEP? Lakshmi, you need to convince a bit more people.
Good afternoon, respected chairpersons. They made a small Tata Nano to go and hit one big Mercedes van. That's difficult, but still I will try to justify my stance on why we should adopt eTEP RS. I am not saying replace, because I was also a IPOM to IPOM plus surgeon for almost say 2 decades, and then slowly have started using this eTEP RS for various of the hernias, ventral hernias. And so coming to the key comparison, already Dr. Bhatia has compared, and we know that coming to the mesh in eTEP, it's extraperitoneal, so there is a less risk of adhesions. Adhesions form in IPOM, and it could be purely peritoneal omental adhesions, but sometimes it is bowel adhesions also. And the infection risk is lower in eTEP RS unless you are not good with your sterility practice. And chronic pain is definitely it's almost not there in eTEP RS, because we don't use any transfacial sutures, we don't use any suturing, we don't use any tackers, which are one of the sole major troublemakers for this chronic pain. And well done, we are comparing at well done surgeries. Recurrence rates are differently lesser with eTEP RS because you have a well placed mesh in a secure plane, so that your mesh displacement does not happen. And cosmetic outcome is definitely better because we are doing an abdominal wall reconstruction, and that also gives a functional outcome which is far superior than an IPOM plus. because IPOM plus patients always have that bulge which we feel in the middle, but a well done eTEP RS, that bulge is not there. Compare head to head with your own patient, you will see that the abdomen looks and works far better than comparing with the IPOM patient. And eTEP RS, because of its intraperitoneal mesh placement, prevents the contact between the mesh and the bowel. And lot of times, what one slide Dr. Bhatia said, that a tool in the hand of a fool is the fool always destroys the tool. Same things happens for the IPOM meshes. You know, IPOM meshes, we use composite meshes which are costly and which have a delicate covering on the visceral side. A novice surgeon can damage I have seen surgeons handling the mesh very roughly and then damaging the visceral coating, and that causes dense adhesions between the mesh and the bowel, and that is the reason why we see the mesh eroding into the bowel, because of the damage to the visceral coating of the mesh. And definitely that much of bad complications are not seen in eTEP RS. And the abdominal wall reconstruction, which is the flavor for the hernia treatment nowadays, it reconstructs the near natural anatomy of the abdominal wall, and then in almost a tensionless plane, which we have experienced in doing groin hernias in all these years. And these are also the literature support from the experts who have been doing these procedures for many years than us. And definitely when the mesh doesn't come in contact with the bowel, there is less chances of translocation of the organisms, and the mesh infection rates are less compared to a IPOM plus. And because we are using uncoated mesh in the extraperitoneal plane, there is less need for going in and removing the meshes. Even if there is some infection, they are salvageable, and you don't need the costly meshes, which not every hospital keeps them in their pharmacy, and the different sizes which you need. But here you can keep a big length of Prolene mesh which hardly costs much to the hospital. So you have different types of hernias requiring different sizes of meshes, but you can keep a single big sheets of Prolene mesh which you can size according to your need at the time. That reduces the overall cost implications both to the patient and to the hospital as well. And pain, as I said, is definitely far less than your IPOM pain, even on day 1 and day 7 or day 30. Even on day 30, IPOM plus patients definitely complain of some pain which is not there with the eTEP RS patients. And because we are staying total extraperitoneal pain, even if the patient had previous abdominal surgeries and we are anticipating adhesions, if you stay in the total retrorectus pain without going to the abdominal cavity, those adhesions which are there will definitely not come in your way, and sometimes there is no need for reducing all the bowel which has been adherent to the underside of the peritoneum, because you don't go into that space. And with better cosmetic and functional outcomes, the patients feel far happier and far better now. And so I would say, in supporting my support for eTEP RS, there are definitely reduced complications in well-trained persons. So first train yourself. If you are not training yourself well, you can't blame the procedure. But the long-term durability is better, and patients are happy with it, and the functional results are good. Thank you all. And Bhatia sir's first question he put, one questionnaire he put, no? I would like to answer some of them.
Sure. Just first slide. Put the
First slide.
My slide.
This is, I would say that you should learn both the procedures, IPOM plus, not plain IPOM. Plain IPOM, go to the first slide. And start doing eTEP RS also, because, yes, this one, questions. Yeah. Does site and size matter? For IPOM plus yes, for eTEP RS no. learning curve is there for all the cases, but if you have been seriously doing extraperitoneal groin hernias in the past, then definitely you can easily learn the eTEP plane. This is more easier than the groin plane, and do complications like PRS disruption occur? They do occur, but same thing also happens if your mesh, IPOM mesh is not placed and fixed properly. We have gone in where the people have tried to save money on using the number of tackers, or not able to put the sutures properly. We have got patients with intestinal obstruction because the mesh has gone between the bowel and between the abdominal wall and the mesh. And fallback procedures, as we improve our experience in eTEP RS, I would say that if your sheet doesn't come together, you have biological meshes, you have micral meshes to help you reconstruct the sheet. You need not go even, and then you learn to use the peritoneal flaps to reconstruct. And then if you are having a recurrence with your eTEP RS in the future years, maybe we can still go back and do a TARM and get the mesh back in the proper plane. Mesh infection, explantation and all, they are not purely procedure related, but they are your sterility related, which can happen with any type of hernia you do. And when it comes to recurrences, I think a learner surgeon should not embark on doing the recurrences, but learn to do the primary surgery properly. And depending on which center you are going, and depending on the expertise of the surgeon, definitely IPOM plus surgeon can do a eTEP recurrence with IPOM, and or a well experienced eTEP RS surgeon can definitely tackle the recurrences the extraperitoneal way. Thank you, sir.
Thank you, Lakshmi. I think it's going to be a good, how much we have? We have 5-6 minutes for discussion. Huh?
3 minutes.
Yeah. Yeah, another thing which I would love to ask Dr. Kona Kumari is, for example, both of us are doing eTEP, that is a different business. If you are doing TEP, and if it is a recurrent hernia, it is a complex hernia, and once you have gone into the retrorectal space, and then you are nearing the sac, are you sure that behind there is no snake? In the sense that sac is seen, and once you know, in IPOM for example, we know right from the beginning that there is a snake behind the bush and one has to be careful. But when we are doing eTEP RS, I am having jitters at this stage also. Maybe I am not sure that in that sac intestine is there or not. Am I going to injure the intestine or not? And if I open the peritoneum at that stage, space becomes limited. So what is the remedy for that?
Yeah, according to the teaching, you don't first go and attack the hernia sac at any time in eTEP RS. You have to create the space well around and then go to reducing the contents. And always, whenever you're in the extraperitoneal plane, even you're doing the simplest of the hernia, always think that there is a snake behind the bush. That is the one thing. When you're extraperitoneal, you don't know what is there behind. So always I go with the mind that there is bowel there, and even if there is bowel and you have opened the peritoneum, you have made a wide extraperitoneal space, then there is not much loss of the space and not much flapping. And actually I would say that even if you make a small opening in the sac at that time, it is good that you can see what the adhesions are and release the adhesions and then close back the peritoneal sac.
I think that is the standard practice, that if you are finding difficulty in reducing the contents, open the sac, reach the peritoneal cavity and see through there whether the bowel loop is coming upwards or not, because that adds to the safety. And you don't lose much space if in a eTEP. You lose a space in TEP in one hernia, but you don't lose space in a eTEP RS. That is true.
One of the things in the hernia surgery is 80% of the ventral hernias are done by IPOM plus, and which means all the surgeons are very familiar with IPOM plus. And if it is not an acceptable procedure, I don't think so many people will do. I agree definitely, eTEP, the learning curve is more, but the cost Dr. Lakshmi was talking about the mesh. So by the time you create the eTEP space, and if there are any rents in the peritoneum, close the rents and all, in a corporate hospital the cost is going to be the same. It's not going to differ. Then you quite rightly said, the mesh infections are technical related, they are not exactly related to the eTEP.
I would definitely endorse your point of costing, in the sense that most of us know, and especially in Gangaram Hospital, I am also again talking, that the charges the surgeon also gets for eTEP for 5-6 hours is more than what he gets in IPOM plus. So ultimately, the cost of the mesh comes down when we are doing the eTEP, but the cost of the surgeon goes up, the cost of the anesthesia goes up, the cost of the anesthetist drugs goes up, and ultimately patient has the similar kind of bill later on.
And the cost of the OT goes up because
OT goes
the
up.
OT is longer.
Exactly.
So more or less the cost remains the
But
same.
one thing is for sure, that the post-operative pain in eTEP is definitely less than IPOM plus, because you are not using any tackers, and it is the tacker which is responsible for pain, not the mesh. So since in eTEP RS you are not you don't need to fix the mesh, because you have a peritoneum supporting the mesh on the inferior aspect. All you need to do is to just spread the mesh, and if at all you are very careful, maybe you can put some fibrin glue at 4 corners so that the mesh does not roll back in the memory. And fibrin glue is not very expensive. It is much cheaper than the cost of the tacker. So the pain is definitely less in eTEP RS as compared to IPOM plus, where bringing the edges of the defect causes tension and pain, and then on top of that the use of tackers, at least 25 to 30 tackers, which are very painful in the post-operative period. So IPOM plus is not as painless a procedure as laparoscopic cholecystectomy or laparoscopic inguinal hernia repair. It is associated with significant pain when you do an IPOM plus, but eTEP is remarkable in difference in the pain. So that point of view, eTEP looks better than IPOM plus.
No, I totally agree with it actually. In the beginning, when you take as Parveen has mentioned already, if you take it in a week's time, the pain score, if you compare it, the pain score between the IPOM plus because of the fixation and the eTEP plus, eTEP RS without fixation is more or less similar only, not completely that greatly different.
So in nutshell, both of us can shake hands that one should know both the procedures, do it well. Full stop. Sure, thank you.
Let's see if there is any question from the floor. Maybe one or we have few fast questions.
Any experience regarding the disruption of the posterior rectus sheath in both the
Sheath properly mobilized and you're sutured under lot of tension, which should not be done. So it will only happen at only 1 or 2 points, and you can tackle them. And it has happened twice to me, and both the patients were on the heavier side.
I would put it this way, that because we know that there is a entity called as posterior sac, the posterior sheath disruption, so we should be more careful in dissecting, one. And second thing is, we have learned in the last few years only that it is more important is to have a visceral sac closure rather than only the sheath and sheath closure. So once you are able to close even the peritoneum on the sheath, but still if you are able to completely close it without any tension, that will give the best possible results.
Yeah, PRS closure is mostly because of a misjudgment on the tension on the peritoneal flap.
True.
And if the peritoneum is lax, it has been closed in a lax way, then the PRS generally should not occur, because peritoneum vascularity is extremely good.
Sure.
Peritoneum has very rich capillary network, so it survives. Generally, the dictum about peritoneal closure says that if the peritoneum looks alright, it is tight. If the peritoneum looks loose, it is alright. So please remember that you must make the peritoneum look loose when you are closing the PRS. If it looks alright, presume that it is tight and do more mobilization.
Wonderful.
Sir, when we are
There is
placing
one cost factor. When we got the robo, we did the cost analysis. We found that IPOM plus for a large hernia, where I use 20 into 30 or a 30 into 30 coated mesh with tackers and a eTEP RS with a robo cost the same.
It's correct.
Cost the same exactly, and the cost, yes sir.
No, sir, but
Yes,
Kona,
exactly.
why should you use the tacker and robot? If
No,
you are
no,
using the
I am
robotic
us-
surgery,
no,
just
I am
future them.
No, no,
Just
no,
future
no,
them.
no, tacker we are not
This
using.
is another topic.
Yeah, it is another topic.
It is not. It is saying that your mesh and tacker adequately sized mesh. If you are using a small mesh and trying to cut costs, it is not there. But a big 20 into 30 mesh easily costs a lakh rupees, Indian rupees.
82,000.
82,000 to
82,000 is
some
25 into 20. That is the largest.
20, 30
largest mesh ever. 30 to 20 is not available.
available, sir.
The largest is 25.
Available, sir. Symbotex has 30 into 20.
Symbotex.
Yeah, 30. There even 30 into 30 meshes are there with Healthium and all. Their cost with the tacker means you use a full round of 25 or 30 tacks costs equal. That's what when we are saying, why I am saying robo is for that big size defect. So you have the comfort of sitting and doing it comfortably, and especially we get all the recurrent hernias, both cost the same. So I don't think hospital pays me any rupee extra because I'm doing it. They don't understand what eTEP RS or it is.
I think in that case, for a large defect, we'll go along with eTEP RS.
Yeah. But because they only bill it as ventral hernia. The robotic ventral hernia or lap ventral hernia. Our billing is not intelligent to understand what is eTEP and what is IPOM.
We are late.
Yeah.
So
Okay.
when we are placing such big meshes like the 30 by 30 mesh, if the patient requires any kinds of surgery, abdominal surgery in the future, like any clues like where the ports are placed, any laparoscopic surgery, what is the thing we have to follow?
No, we have gone into abdomens where we have put 30 by 30 mesh, IPOM plus we have gone in. There will be, because your entry point will be in the epigastric region, because you are not covering up to the xiphoid, so you enter there. You enter just below the xiphoid, then you go beneath the mesh and put the one port quite laterally that comes almost in the lateral flank. Use that port to do the adductolysis and then put the other ports away from the mesh, even whether it's IPOM mesh or a eTEP mesh. Definitely I would not say that after 4 or 5 years of a good hernia surgery, you will pierce through the mesh and create a defect there. Learn to put your ports wide, maybe a little away from your normal ports, and learn to do the surgery.
In any case, just again, though I know that I was against her, but if you have done eTEP and if you are going into the peritoneal cavity, the surfaces are absolutely smooth, not like IPOM plus.
Clean, yeah, very absolutely clean. It will be like a normal abdomen inside. I have done a patient eTEP RS 2 years back, and later she needed a hysterectomy. All the gynecologists refused her. They said we'll open. So she came back to me. I did her hysterectomy. I went into the abdomen. I was really happy. I saw not a single addition.
In fact, hernias of childbearing age in the females is an indication for eTEP RS rather than IPOM, because the subsequent surgery is not as difficult in eTEP RS. So if generally we do not repair hernias in
Childbearing age.
but if we have to, then we prefer eTEP RS over IPOM.
Yeah. Yes.
Thank you.
Okay, thank you. I
Thank
think
you,
we
sir.
need
Thank
to
you.
conclude
Thank
the
you.
session
Thank
because
you,
we are
thank you,
late. We thank